Hey everybody, this is Eric with FlightBridgeED. I just want to welcome you to part 2 of our advanced hemodynamic monitoring series. If you haven't caught part 1, we looked at the pressure bag, the pressure setup, how to set that up adequately enough to where you're not going to have error, you're not going to have any kinks, things like that. We talked about the transducer, we talked about the phlebostatic axis and the importance of making sure that's in the correct spot, zeroing the monitor, and kind of everything that has to do with the initial setup of your pressure bag. If you haven't seen that video, you can look in the show notes for that link and get brushed up on that. And this is going to be part 2, like I said, and we're going to dive into the actual central venous catheters and the Swans, the pulmonary artery catheters, and look at what that means, what they do, and the different ports and things like that. So let's get started. With advanced hemodynamics, I think it's really important to not know what's going on with the patient when you teach this concept. You know, we all have seen a lot of questions. Many of us have been in this field for a long time. If you're watching this video and you're new to the field of critical care medicine and you're just starting to get into that, we welcome you. And, you know, one of the things that is important is to be a good test taker and remember key terms that are on quite a few exams that should trigger you to be able to look at a diagnosis just from the perspective of the first couple sentences of a test. Based on that, you know, and my experience is I want to teach this from the kind of the mindset of just looking at the numbers, and from the numbers know that is leading you down a differential diagnosis pathway. It's going to help you look at these numbers in a different way. So if we look at the first sentence, this patient was intubated, has a heart rate of 58, respiratory rate of 12, and a blood pressure of 76/46. O2 saturation 94%. So if you've ever taken advanced medical life support, if you've ever taken PHTLS, those 2 lectures are really good about talking and discussing things regarding shock and our ways of compensation, our ways of not being able to compensate. So going from that compensation side to the decompensated side. In this situation, you have a heart rate of 58 and a blood pressure of 76/46. So for me, my red flags go up. Why is the heart rate so low? How old is this patient? Do they have any medications that could be blunting their compensatory response? Are they on a beta blocker? Or is this patient an athlete, a marathon runner that just constantly runs low? So why isn't there any response? Why isn't there any compensation? This patient's blood pressure obviously is extremely low. So, you know, what's going on? What type of shock could cause this phenomenon? If we continue, the patient was sedated and paralyzed in the field. That's not really relevant to this at this point. Ventilator settings, the patient is on the ventilator on assist control volume at 700, FiO2 of 100%, frequency of 10, and a PEEP of 23. Again, we'll look at ventilator concepts in other videos as far as kind of the pathophysiology and the approach. So for this, we're going to move on. The patient's had an arterial and pulmonary artery catheter placed prior to your arrival. So essentially, kind of to set the tone, you have been called to a referring facility for transport of a trauma patient to a level 1 trauma center because that facility does not have the capabilities to take care of the patient. If we look at the last line, the CVP of 0, PA of 14 and 3, a wedge of 2, and a cardiac output of 6.4 with an SVR of 687. So if those numbers are overwhelming to you, if you're looking at that going, well, what the heck does that mean? We're going to look at these over and over the next 3 or 4 modules. And by the end, I want you to be able to look at those numbers without anything else in front of you and diagnose. Before we jump into the or have a good meat of this lecture, let's just kind of touch base on a central venous catheter. Central venous catheters are placed all the time. They're placed for different reasons. Different physicians will place them, and then I see other physicians that will stay away from them. But the point to a central venous catheter is to get a good access point where they can infuse medications. They know they're not going to have any issues with infiltration, movement, and things like that. Certain medications are better to be administered via a central venous catheter, like potassium, like what else? Calcium, things like that. So calcium chloride is something that you would never want to put in a peripheral IV if you didn't have to. If it infiltrated, if it extravagated, that's going to be a real bad thing. So a lot of times they're going to be placed for patients in some type of vasodilatory shock that needs a good access point for multiple reasons. There's multi-port and single-port types of catheters, and these are placed via a cordis, so they're placed either in the subclavian or the IJ. These are utilized for multiple reasons. So you can see this picture here. You have a white port, a red port, and a blue port. The white port is going to be used for infusions like TPN. So TPN is a great example of why they would use that white port, giving some type of nutrition. The red port, and oftentimes it's called the brown port, is going to be used for blood draws, and they can draw an SVO2 off that if they need to. And then the blue port is going to be for normal medications, normal drips, infusions, fluids, and things like that. So your blue port is going to be your main port. Every time that you use these ports, it's important to flush these. Oftentimes they'll flush them with a little bit of heparin to make sure there's no clot that's formed. They'll flush it with saline afterwards. Just make sure that it's always free-flowing, that there's nothing that's going to hinder further infusion. This is a great picture, so we're going to spend a little bit of time on this. You can see that there's multiple ports to this pulmonary artery catheter, and this is what's called a Swan Ganz catheter. Now, these catheters aren't used like they used to. Back in the 80s, early 90s, these were extremely popular. They were placed all the time. But nowadays, you don't see them like you used to. I don't think I've seen maybe 10 in the last 5 years being a flight paramedic. So I think it's very specific to a disease process. They're used in, obviously, open heart surgeries. They're used a lot in sepsis. But even specific physicians around the country, around the world, are starting to get away from using a Swan because they've shown that there's no improvement. There's no increase in patient survival. So, morbidity and mortality has not been improved by placing a PA catheter or a Swan. We have multiple ports, like I said. The very two top ports, they're in white. Oftentimes, there's a red cap and a blue cap. Those two are used for your monitor connection. And then the blue cap, the cardiac output aspect, is used to identify a consistent cardiac output. Now, the thing with the cardiac output, in the old days, and I say old days because I never have done this, they didn't have this capability. And this was actually done based on a fast flush. They would get a 10, 20 cc catheter, or I should say syringe. They'd fill it with ice cold normal saline, and they would inject that in that PA distal lumen, which is the looks like the fifth port down in yellow, and we'll talk more about that PA distal lumen here in a second. But they would fast flush this, and this is going to give them an idea based on a calculation and all that, and I it's not really important for this. But the problem with that is you could have two different people check this cardiac output. You could have a guy that has strong hands. They push that syringe really rapidly, and you could have a female that maybe doesn't have the same strength, and they would push the syringe slower. And you have two different people pushing that fast flush, maybe just minutes apart on the same patient, and you could have a huge difference in your cardiac output readings. So I don't think that it was very accurate. You had to be very consistent, and each syringe that you use, as you may know, may have a different friction based on the plunger. They don't all work the same. So there's a lot of things that could have hindered a proper cardiac output measurement. Now we're going to jump all the way down to the fifth port, and this fifth port is called the PA distal port, and this is really important to understand. This is where, if you remember in video 1, we looked at setting up our pressure monitoring bag, our drip set and all that. We learned to make sure we have no error in the line. We don't want any kinks. We don't want anything that's going to impede the flow. Remember, we want 2 to 3 cc's per hour of flow through that tubing. And that's not very much, right? The whole purpose of that is to actually connect to this PA distal lumen. So we're going to connect that end of that drip set, end of that transducer to the PA distal lumen, and that's where we're going to now utilize for a PA waveform. So when we learn about the different aspects, when we learn about CVP and our PA and our wedge, we're constantly identifying and monitoring a PA waveform. So that's what we use that for. The second reason we use this PA distal lumen is to draw an SVO2. When we look at how our patients utilize, consume oxygen, it's very, very important to understand consumption based on delivery. How much oxygen are we delivering? That's the content of oxygen in our arteries. And how much are we delivering based on the cardiac output? That's called DO2. So we look at that and we actually compare that to the consumption aspect. And an SVO2 is going to tell you consumption. So an SVO2 is something that we want to keep in the 70-75% range. And for sepsis, specifically, they try to gauge 70% is where they want to keep it. So they'll continually draw SVO2s, maybe hourly, every couple hours, to see if we're trending upward or downward. When we, you and I just sitting here right now, we deliver an abundance of oxygen in excess of what we utilize. So whenever we deal with patients, it's always important to look at, are we meeting the demand? Are they consuming more oxygen than we're actually delivering? Or are they getting proper delivery and their consumption, their cellular consumption of oxygen, is it adequate enough? And we look at this SVO2 for that purpose. So what they'll do is they'll draw this, they'll identify, do we have an SVO2 of 72%, for example. And an hour later, they'll recheck it. Now we have an SVO2 of 68%. So we're actually going backward. That means that their demand is far exceeding the delivery that we're providing. To give you an example of how much excess oxygen we have, for you and I sitting here right now, we deliver about 1,000 mils of oxygen per minute. And that's based on a calculation that I'll show you in later videos, where we take the hemoglobin concentration, we multiply that by a number 1.34, which is the amount of oxygen in mils attached to a hemoglobin molecule, and then we multiply that by our O2 saturation, our saturation of arterial O2. We utilize that and we constantly evaluate that based on perfect numbers, right? For teaching purposes, that's 1.34 mils. That's a perfect saturation. We look at a perfect hemoglobin of 15 and a perfect O2 saturation of 100%. That gives you about 1,000 mils a minute of O2 delivery. And we use a very, very small fraction of that. So there's a huge amount of reserves that we have available in situations of sympathetic response, that fight or flight, in a disease process, in that sepsis. But we eventually will utilize all that up. Remember that oxygen is transported and stored in your plasma first, and then the excess is actually stored on your hemoglobin. So 2% is transported in your plasma. We always utilize the plasma stores first, and the rest is on your hemoglobin. So that's where an SVO2 is really, really important to be able to constantly check, and that's a great thing with this Swan. The next connection that we will talk about is the number 3 and number 4. So that blue number 3 and then the white one right below that. Those two ports are going into the central circulation as far as the right atrium. If you go all the way down to the bottom, you can see this proximal injectae lumen and proximal infusion lumen, and they're pointed out at 30 centimeters and 31 centimeters. Those are the main ports that you're going to utilize to infuse medications. You can give TPN, you can give fluids, hang drips, you can do an abundance of things with those two ports. So you have two different ports to access that central circulation. We can also transduce a second waveform. So we can do this in two ways. We can set up a completely different monitoring system, pressure bag, the transducer, everything we went over in video 1. Or you can actually use what's called an H stopcock type connection, where you can have the pressure bag set up to hook to this blue port, for example. You're transducing your PA distal lumen that we discussed earlier. We're getting a PA waveform, and if we wanted to identify a CVP waveform, we would just turn the stopcock. We would shut off the connection to the PA distal, and now we would transduce and we would see that waveform change to a CVP. So it's very, very important to know the capabilities of the catheter, what you can do with it, and this is a great way to look at your heart from a different perspective. Your last port that we're going to discuss here is, I should say, we got a few more. So your thermistor connection, that's going to be that second yellow connection. That's a connection that we can see actual thermodilation measurements. What's our temperature? And so it's important, obviously, to be able to identify a temperature. And so all Swan catheters or Swan Ganz catheters do not have that capability. Only specific ones do. Your next one is your red port. That red port is really important. You can see that that red port is used to inflate the very tip, that distal tip. That distal tip is the PA lumen. The PA distal lumen goes all the way down to the very bottom, and at the very bottom you have that distal balloon. That balloon is utilized to occlude the pulmonary artery when we place this in the wedge position. Now we're going to talk about that more specifically in video number 3, but a wedge position is utilized to identify left ventricular end diastolic pressure. Very, very important when looking at your left side of your heart, left side preload, afterload, what's happening during the diastolic phase. Are we having proper diastolic clearing and filling? So that's where we would utilize this balloon to put into a wedge position. The important thing about this red port is we only fill or attach a syringe that goes with that catheter to that port. You're never going to utilize just a standard 3, 5, 10 cc syringe. It has to be specific to this catheter. The reason being is that balloon will only inflate to about 1.5 mils safely. If we inflate it bigger than that, we could cause a rupture of that pulmonary artery, and we obviously wouldn't want that. So that allows us some safety, and essentially what you're going to do is you're going to hook that syringe up and you're going to slowly start filling that up. If it only takes 1 mil of air to inflate that balloon to where you see a waveform change, then that's where you stop. So for test purposes, if you're studying for your FPC, if you're studying for your CFRN, always know it's 1.5 mils of air or whatever fills the balloon to capacity to allow yourself to see a transduced wedge waveform. All right, so whatever comes first. If it only takes a half cc, then that's all you need. So very important to always keep that with you, take it with you. Make sure that when you, if you do pull this back at all, which you probably shouldn't have to, always make sure that balloon is deflated. We never want to pull it back and obviously cause a rupture as well. Then the last is this inducer with side port. That inducer is actually going in through the skin. It's actually kind of allowing you to slide this catheter back and forth. It's going to have a safety sterile piece of plastic on the port to where you can keep some sterility. But on the side, it's got this inducer with side port, and that side port is a very large straw-like port that you can infuse fluids rapidly. I mean, it's a massive port. It's like a big straw. So if your patient was decompensating, you needed to give a lot of volume very, very quickly, you can infuse it real rapidly through there. And that's going to come out and be evident, come out in those 30 to 31 millimeter ports that we talked about with the proximal injectae and proximal infusion ports. On the next slide, we're going to discuss this in kind of more depth. We'll review this, and then I'll do a demonstration video on how this is actually placed. So just for review, remember that it's placed into the vena cava, which obviously travels into that right atrium, but oftentimes it's in the internal jugular or the subclavian. Those are the two main places. You can place this in the femoral vein. It's not the most optimal area. Obviously, you have the bend of the leg. You don't want any kinks or things like that. So the IJ is actually the best place, very accessible. Remember, it's a great tool to monitor what's going on the preload side and the afterload side. It looks specifically at right atrial pressures, which gives you a good indication of preload, gives you a good indication of fluid fluid resuscitation needs. And then your PA and your wedge are great measuring tools to look at the left side of the heart, look at your left ventricular end diastolic pressure, and what's going on. Does it match their history? Does it match their presentation? And we'll look at all those things in more depth in video 3 and 4. And then the catheter on the central venous side, those proximal injectae, proximal infusion ports, that's where we're going to give fluids, medications, drips, and things like that, TPN. Now let's look at a demonstration on how this is utilized. Now let's look at a few pictures and kind of illustrate how this is set up initially. So you can see these pictures here we got our picture on the left. This is just a demonstration of this catheter in the kit. It's being set up, it's being flushed, make sure there's no air. All the ports are flushed and ready to go, and they've inflated the distal tip balloon to make sure that it's not popped, there's no holes in it and things like that. And then the picture on the right is just an illustration of it placed in that IJ, and you can see it's secured. It's got that plastic sheath to where you can advance it forward and back and keep sterility. And this is going to be secured and checked often and documented often that there's no movement once it's in the PA artery or pulmonary artery and secured. All right, so now let's look at a demonstration. This is where we actually have the balloon is going to be inflated. The doctor is going to say balloon up. We're in the right atrium. At this point, you can see we have a CVP waveform. We go through the tricuspid valve, and now we're in the right ventricle. It continues through the pulmonic valve, and we're now advancing up into the pulmonary artery. So you can see the waveform has changed now. We're on the third waveform change, and now you can see that we're actually in that pulmonary artery, and we have the balloon inflated. The doctor will say balloon down. He's going to pull it back. He's going to say balloon up, and he's going to advance it forward and see a waveform change, and that's going to give you that wedge waveform. Once they see that wedge waveform, then what they'll do is they'll say balloon down, and they'll secure it in that place. Now what this video is illustrating is those thermal filaments that are utilized with that thermistor port to identify that thermal dilation. What's the temperature? How are we doing temperature-wise? And then we have to remember that you can utilize this for this catheter for cardiac outputs. And then some of these catheters actually have another port. It's got an orange tip on it. It's called right ventricular port or a pacing port, and they can do internal pacing and things like that through that port. So multiple ways that we can utilize this catheter. And then to kind of sum up this aspect of this part of the lecture is I just wanted to discuss a few things prior to moving to the next phase of this video series. When you look at how we deal with advanced hemodynamics, there's a lot of things that come into play that affect our cardiac output and our oxygenation status and things like that. So DO2 is the delivery of oxygen. And essentially what that is we take a formula that I discussed earlier where we look at the saturation of hemoglobin, we multiply that by the hemoglobin concentration, and we multiply that by the amount of oxygen stored on hemoglobin. And then we take that number and we can multiply that by their cardiac output. And that's going to give you DO2, the amount of oxygen we're delivering per minute. So you can see that cardiac output plays a big role in that, but the biggest role in O2 delivery is your hemoglobin concentration. So if you have a patient, any patient you're transferring, if this is a transfer, the first thing that you should always be looking at is what is their H&H. we have good hemoglobin concentrations? Do we have good O2 carrying capacity? If you don't, that's going to significantly reduce the ability for your patient to not only store oxygen, but utilize those stores when needed. So a big deal to identify your hemoglobin concentration. The next thing, the most important thing, is your cardiac output. Well, what is the driving force of cardiac output? It's oxygenation. Oxygenation, though, can't happen without a proper hemoglobin concentration. So you don't have a proper hemoglobin concentration, that's even more of an important aspect to optimize oxygenation, whether it's via advanced airway management, putting them on the ventilator, optimizing their oxygenation with good recruitment, good maintenance of those alveolar recruitment with PEEP, and going that route. But cardiac output is also related to our heart rate and our stroke volume. If our heart rate is too fast, if we have a medication that's being given that's causing the heart rate to be too fast, or they're hypoxic and their heart rate is too fast, or are they in a lethal rhythm, then you can't adequately clear your left ventricle or fill your left ventricle with blood, and that's going to hinder the stroke volume and the amount of ejection out for oxygenation purposes to the rest of your body. So heart rate is a big deal. Are we too fast? Do we need to slow it down? Are they on a medication like dopamine that's at 20 mics and it's basically causing a reduced cardiac output? Can we go to something else? Are we giving a medication that causes a transient effect in heart rate that hinders? Your patients obviously are sick. Do they have a cardiomyopathy, a dilated cardiomyopathy that causes a decrease in the ability for that left ventricle to contract? So these are things that we have to think about. What is going to fix the cardiac output? And then SVR. SVR is obviously the squeeze. How much systemic vascular resistance do we have? So there's a formula here. We're not going to kind of go into this right now, but the formula for the critical care aspect of SVR is you take the patient's MAP, you minus their CVP, and then you divide that by their cardiac output, and then multiply that by 80, and that's going to give you an SVR. And that's important for a lot of reasons. We're going to look more at SVR later in probably Module 3, but SVR is something that we have to have for normal compensation. If you don't have good SVR, if you don't have good squeeze, then there's a reason why. So we're going to look at why that is. That is going to be the conclusion of this part of the lecture. Remember, go back and review Module 1, refresh on setting up that pressure bag, review this again. If you have any comments, please email me. My email is going to be at the bottom of the show notes here. You can always comment. That's how we learn. I gain wisdom, you gain wisdom. We foster a good learning environment. I want to hear your thoughts. I want to hear your ideas on new content. I'll present anything you guys want. And we will see you back on Module 3, where we're going to start looking at the different aspects, the waveforms, the CVP, the PA, the right ventricular waveforms, the wedge. We'll look at what those are, the pathophysiology behind those numbers, and then we're going to progress to looking at more patient scenario-driven cases and applying everything that we've learned. So I want to thank you for joining me, and I will see you on the next video.